Good evening. This is Erin Beignet from the Society for Post-Acute and Long-Term Care Medicine. We'll be starting in just a few moments.
Yeah. I wonder whether he should just start all over again. And I feel a little bit uncomfortable about not starting. Mm-hmm. Yeah, let's go and get started.
Go ahead. And you're all set. You're all set to go.
Okay. Hi there. We apologize for a few minutes lateness here. One of our speakers has some technical difficulties, the famous technical difficulties, but I'm sure he will log on eventually. Good evening and welcome to AMDA COVID Grand Rounds, Pearls from your colleagues, and happy hour on the East Coast. I'm Sabine von Price-Friedman with the Washington State AMDA chapter, your host. And this is part of an ongoing peer discussion on COVID-19 in the post-acute and long-term care space. We know our patients have some very specific needs, and we want to make sure that we learn what we can about what serves them best through data or practice. In other words, we want to hear and learn from each other's maybe mistakes as well. Today, we want to address a difficult topic, advanced care planning with our patients and families in the setting of COVID-19. Now, this is meant to be an interactive discussion, and I encourage you to use your chat function. Please do. We want to ensure that we get the questions that you want answered and also your suggestion, because this is really a peer-to-peer, and you are certainly one of our peers. Although there is an overall impression that there is a lull in the spread of COVID in nursing homes, we as medical directors and physicians in nursing homes also know that there's a good chance that there may be another COVID surge ahead of us. Now is a good time to plan. And that includes advanced care planning discussions. To start us off, here are a few areas we want to address in tonight's webinar. How does COVID affect advanced care planning? What about the isolation of our patients? Our patients are isolated from their loved ones and potentially from their physicians. How do we do advanced care planning then? What tools do we have to help us in our discussions with patients and their loved ones? Here to help us to examine how to have this conversation in the very best way are three AMDA peers, and actually, hopefully four if Dr. Steinberg joins us. Dr. Kevin Henning, he is a board member of our chapter in Washington, and he widely lectures on Vital Talks. Dr. Jessica Calendar-Rich is a medical director, I'm sorry about this, and a PA, LTC, and hospice physician. Dr. Brian Yeaman developed advanced directive internet platform, and we are excited to have you here too. And then Dr. Steinberg is our president-elect. He needs really no introduction, and he developed AMDA's advanced care planning tools. Let's start out with our poll. Erin, would you get the poll started, please? I've good news. It sounds like Dr. Steinberg has successfully joined us, so that's great. And here is the poll results. To the question, does the COVID-19 pandemic affect how you have goals of care and advanced care planning discussions and conversations? A minority uses a structured approach or checklist. Most people use the standard polls form. And a sizable chunk, about a third of patients, use their intuition based on patient-specific circumstances. So this is kind of an interesting result. I mean, I think the pulse form was predictable. I think what I'm really pleased to see is that nobody said, I don't have time for these conversations. Jessica, Dr. Callender, what do you see in your hospice work in this regard?
Yeah, so we're seeing a wide variety of hospice interactions in nursing facilities right now. There are certainly facilities that don't want to let hospice providers into their building for fear of additional quote-unquote unessential workers coming in. We see other, and that has even led to a couple cases where the facility wants to send the person to the hospital when they're actively dying rather than bring in a hospice nurse to help treat their symptoms. On the other hand, we're seeing places that have really done well to set up separate units that can be places for hospice to occur, and that families can come directly in and see their loved ones for that compassionate care visit. It's so variable across every facility. The challenge, I think, has been in actually getting to some of the goals of care, because it's particularly for our patients that have like cancer or chronic diagnoses similar to that. As many of the clinics closed, they weren't being seen by those long-term providers, and then other people, perhaps the SNF physician or long-term care physician, were actually having to identify their trajectory, which we do all the time. And at least in my practice, when we do that, we communicate closely with their subspecialist and then have goals of care conversations. That became much more difficult as everything became much more divergent from on-site care.
Mm-hmm. So are you doing televisits right now, Jessica, or are you doing on-site visits? Or
So
is it
most
variable?
It's a combination. A lot of the on-site visits are being done by the nurses who are going and providing medication administration, and then televisits for those face-to-face encounters or some symptom management as able. Really because, we, as much as anyone else, don't want to be the spreader, right? So I know that many of us that work in facilities, I know I only go to my one facility, and I've divided out the whole team so that there's one provider for a facility when able, and we kind of have done that in the hospice world also.
Okay. So challenging probably having the televisits, or is it sometimes easier to have a televisit? Because for me, it has been both. So
I think it's both. For me, the televisit is easier, one, because I don't have to wear a mask, and so the communication, I'm sorry that my children run like elephants through my house. The communication is much easier without the mask on, frankly, and they can see my expressions, and we can, they gather the empathy that I normally probably wear on my face. The other thing is I found it actually much easier to pull in a family that lives all over the place. And historically we might have just brought in someone on the phone line, or maybe only the local family, and now we really have the ability to sit in a room like we are sitting right now, see everyone's face, see their emotions, have those conversations. And although we can't necessarily hold the hand of the person we're talking to, we're adding a different dynamic that is still of benefit.
It's interesting how some of what we are now experiencing in the COVID world is something we might carry on moving forward. And I think that the televisit to family members is certainly something that I have enjoyed, and some of my patients actually prefer televisits. Beats me why you wouldn't want to see me in person, but hey, they feel maybe more comfortable not with that direct approach. Now, Kevin, you're using a structured approach. Tell us about your structured approach and how COVID affects those conversations.
Yeah, so in my work, I've become familiar with structured approaches to goals of care conversations for the last several years now. And there are a number of organizations that publish guides to goals of care conversations. And it occurred to me that, in the COVID pandemic, one of the silver linings is that many family members are now welcoming these conversations. They're grateful that we called, that, they want to talk about their loved ones' goals and what might happen, or what they would want, what would be important to them if they got sick. And I think even in the setting of the pandemic, I think we would be well served by using a structured approach. As I said, there are a number of organizations that have published on this. The one I favor is from Ariadne Labs, but Vital Talk has guides on respecting choices. In fact, I just noticed, like a half hour before our call, some of our colleagues published in JAMDA a structured approach to how to have these conversations in the setting of COVID. And I think the advantage of it is that you don't miss things. If you use a structured approach, you kind of cover the important pieces in the right order. Some of the guides, like the Ariadne guide, uses evidence-based language that has been proven to be valuable to patients and families. And in fact, they have research that shows that in clinicians who are trained to use those guides, that they can show, compared to a control group, that the patients got more earlier and higher quality conversations. Now, of course, that research was done pre-pandemic, but like the other groups, they've published, kind of the COVID version of how you might have these conversations. So I would encourage people to look at those options when they're talking to their patients and families.
So yeah, that'd be great if we, Erin, if we could put that article from JAMDA that you just cited, if we can put that under the COVID resources on the website. And can you tell me just a little bit in a nutshell, I know you and I have had conversations about it, but what Vital Talk actually is and how we can learn more about that?
Yeah, Vital Talk was founded by a group of palliative care physicians and other clinicians. They're mostly academics who do research, have all kinds of online resources helping clinicians through difficult conversations of any type, sharing bad news, having a family meeting that's difficult, and specifically, the goals of care conversation. They have a great website. They've got an app. They within a week or two of the pandemic, they published a guide that helps clinicians with some of these challenging conversations. So I would definitely check them out online. They've got videos that you can watch. And again, they weave in the evidence base too. They'll mention, why they suggest a certain language or a certain approach based on either, their research or their expert opinion. Okay, well, thank you.
So, Carl, I hope you can hear me and can talk. If you can unmute yourself, that would be awesome. So I know, Carl, you also, just like Kevin, have done a lot of work on advanced care planning. You developed the advanced care planning guide for AMDA. And tell us about your experience in this pandemic and what challenges you have faced with advanced care planning and what your solutions were.
Sure. Can you guys hear me okay? I'm using both the phone and a computer. You can, good. And thanks for inviting me to be part of this. So both Kevin and I are active with National Pulse. It's probably worth mentioning that. I think Pulse for me was a big change from back in the old days when there was no such forum, and you'd spend a bunch of time at the bedside talking to a nursing home resident and figuring out what they wanted and writing orders that were good only within the four walls of the facility. And as soon as the patient left the building, it was as if that conversation never occurred. So I think it was a nice addition to our armamentarium, even though it's not, I think it gets misused a lot in nursing homes and is completed for people that really don't have any business doing a pulse form because they just want usual care. But anyway, that's a whole nother webinar. So the AMDA Advanced Care Planning Toolkit is something, really Pete Jagger probably did more of the work on it than I did, and there were others. But it's available on our website. And we're collaborating with a company called AdVault that will be, or I want to make sure I'm saying it right, but that will have sort of a template that can be used in nursing homes. And that way you can bill for the visits. I'll just make a slight political statement. Some of you might be aware that Representative Steve King from Iowa just lost the Republican primary on Tuesday. This was a guy that every year since he was one of the death panel rabble-rousers, I guess. And since that time, every year he's tried to introduce legislation so that we clinicians would not be able to get paid for having advanced care planning conversations. So I'm hate to celebrate somebody losing, but I kind of am. In any event, I think that's a useful form. I also think, the Coalition for Compassionate Care of California has some nice decision aids, and lots of other people do too. These are written at a kind of a very low health literacy level. There's one for tube feeding, there's one for advanced care planning, there's one for ventilators, and there's one for CPR. And I think during this pandemic, for me, it's been interesting that some people I come and I say, you've heard about the pandemic, let's talk about, does that change anything? And they're almost outraged. They're like, how dare you? You think I don't still want to have CPR or go on a ventilator? I don't really care how bad my chances are. And they sort of take that attitude. Other people really appreciate it. And I've had a number of people who've actually changed their treatment preferences on the basis of the pandemic and on the very poor prognosis that people have with if they land on a ventilator and that sort of thing. And especially right now with the no visitation, for a lot of our long-term residents, the closest thing they have to family right now is the CNAs and the nursing staff and so on, housekeeping, that know them. And to send them to the hospital where it's a completely unfamiliar environment, some people have just said, no, I don't want to do that, just to do what you can for me here.
I would like to actually clarify, thank you. I would like to actually clarify your understanding in that's directed to all of you. What is the prognosis if for a older nursing home patient or for any nursing home patient for that matter who develops severe COVID and needs to be intubated? What do you know?
Well, the numbers I saw from New York were something like a 3% survival rate, and I don't think it hadn't gone all the way out to the end, so it may be a little higher than that. I don't know, but it was really bad.
Yeah.
And obviously, if you're so sick from COVID that you then have a cardiac arrest, I mean, right, your chances are going to be nil. They're almost negligible anyway in a nursing home resident, especially when you talk about a meaningful recovery.
Yeah, yeah. Does any of your patients has ever done anything such as, well, this is a pulse or this is a COVID specific end of life decision? So, hey, if I have a pneumonia, I want to be intubated, but if I have COVID and pneumonia, I don't want to be intubated. I mean, I would think that there are some nuances that are creeping up because, somebody who's otherwise, intubation for a non-COVID pneumonia may not hold that same threat. Although I have to admit, I don't know what that survival is right now for just a healthcare acquired pneumonia is probably not great either, but it's not as dismal, and it is not a disease likely that's affecting the whole body in so many ways, such as COVID. Have you encountered that at all?
Yeah.
Yes, I've had a couple of patients. Go ahead.
Well, I was going to say that you can certainly fill in the gaps, Carl, but this issue came up with National Pulse. Is, should we create a COVID post or a temporary post? And we decided no, but that the post form in most states includes a section where you can elaborate on certain conditions that might lead to certain treatments and other conditions that would lead to other treatments. So that's how we dealt with that challenge of the fact that COVID pneumonia in particular would have a much worse prognosis perhaps than other types of pneumonia. Yeah. So
you would then write what, for example, give us an example what you might write on a post form.
Yeah, I mean, I guess you could something to the effect that in the event of COVID-19 and an associated pneumonia and respiratory failure, do not resuscitate. In the spot that allows you to elaborate.
Yeah, there's that free text spot. So you could write in there, do not intubate in the event of COVID-related respiratory failure, something like that.
Mm-hmm. Jessica, what have you seen?
Well, I was going to say that we have seen exactly that differentiation between, even for do not hospitalize, right? So some people would say do not hospitalize if I'm COVID positive, because the actual things that they could do in the hospital, short of intubation, could probably be done in some facilities. What we have also seen is it's hard for the facilities themselves, at least in my area, to understand how that advanced care planning is different. So the documentation of that conversation and how it's put into the electronic health record is really challenging for the facilities that our group goes to. And they sort of struggle with what if it's someone I don't know if they're positive or not yet, and how, and they want to get all of those pieces in a row, and it's a little bit abstract for them to sort of understand how someone could have differentiation of their goals depending on diagnosis. And perhaps that's just the culture of the region of the country that I'm in. I'm not sure, but it's been a huge learning curve for them.
What advice would you give a medical director who's struggling with that issue? Because I can see in PCC it's like code, no code, right? I mean, it's like
right. So PCC is a great example. We actually have added a box when we put in the DNR. And then I hit, at least in the ones in the facilities that I've put these orders in, I can hit enter, and under it, I can put a whole paragraph about what they want, and it flashes into the banner.
Okay.
So it took a long time to figure out that you could do that.
I did not know you could. So it's maybe another webinar. What can you do? We're going to get to Dr. Yeaman here in a second.
So just that's one of the ways that we've adapted. Another way is, really just like was mentioned, writing it at the top of every document. But even struggling to, when you sign, so we have a form called TPOP, which is the same as a post form, but it's actually not accepted in every hospital because we're right on the edge of Missouri and Kansas, and it gets very politically challenging. And so we actually have to have an outside DNR form and a TPOP sometimes so that we have the right documentation to send. And then you can imagine how challenging that can become.
TPOP, that sounds like candy or something, but...
Right, it's a transportable physician orders for patient preferences. It's what happens when you're in a very, very red state.
Yeah, the number of ways you can call POST in this, there's like over a dozen different acronyms or abbreviations for the POST program in various states. So it's not just POST and MOLST, there's TPOP and all kinds of other ones, depending on the state.
Oh, I didn't know.
Yeah, there's Coast and Post and all kinds of, but I have to admit my very favorite is T-Pop. I love that. It sounds like a rapper or something, right? Yeah.
It is kind of cute. Well, speaking of documentation and how to make this available, I'd like to pull in Dr. Yeman into this discussion. I actually don't really know what AdVault is and how it fits into this discussion, but I know it's exciting and new. So do tell us. And it has to do with in cloud storage of advanced care directives.
Yes.
But you tell us.
Yeah, so advanced care planning, you know, so many of the challenges around that have already been discussed tonight, but basically portability, the ability to make sure that that document moves across facilities, the multiple types of documents, special factors such as COVID, how do you handle that? How do you handle the conversation with the families? How do you train providers and make them adequate and or excel at having these conversations? All those are of a tremendous challenge around advanced care planning. And so we get a lot of strategies, obviously nationwide. But what AdVault is, and my directives is the specific solution. We do digital advanced care planning. And so the advanced care plan can be, number one, portable between the patient, the provider, the family, the proxy, and or the health systems or health information exchanges. And so number one, it's available when the patients need it, because we don't always know when that moment's going to come, of course. And then the other element is, you know, how do we go about approaching that in a way that's practical, you know, for patients and families. So we have three mechanisms basically by which that can be done. So one, patients can go self-enroll. So patients in assisted living or senior living may be capable of doing that. The other, and so we have, you know, web portal and or a mobile device access, so through iPhone app, that type of thing. That's a pretty high level of sophistication for some of our seniors to download apps, obviously. But the other major component is by invitation. So that can happen directly to the patient and or their healthcare proxy. And then the third way is a nurse, a social worker, the physician, an advanced care practitioner can start and facilitate an advanced care planning session with the patient. And with AMDA, what I've been able to do is the decision support. So as you go through the questions in our advanced care plan, the guidance from AMDA is actually present in terms of how to do that advanced care planning session to help answer questions for the facilitator. So to me, you know, it's about bridging those gaps. And then specifically around COVID, what we've tried to do is create, so there's additional comment boxes where patients or family members can type in additional instructions or individual preferences, who they are, which I think is a key factor. And then
that would be good for COVID. I mean, that would be perfect.
And then we've created a template of a statement that can be basically an addendum to add to that. But not only do we offer our advanced care planning module, but we also allow any state form, any pulse or pulse variation like T-Pop to be included. And, you know, that, because we recognize there's going to be multiple ways to document this, and it's one size fits all. So, you know, we try to make the platform pliable and flexible to meet the needs of the caregivers, to meet the needs of providers, to obviously meet the needs of the patients when those advanced care plans are needed. And it's, you know, it sounds like a relatively simple endeavor to just stand up and start doing, fill this form out online. But there's a lot of pieces that go into that in terms of making that document portable and actionable. And we've been a long period of time to try to make this solution make a lot of sense for patients and providers.
So just a follow-up question then, is it out yet? And what are people saying who are actually, is any of you using that ad vault if it's out? And what are the challenges, or what are the good things that you have, what's the acceptance rate? I wouldn't even know how to offer that to a patient. I'm glad if I get the polls done. So how's it looking in practicality? Carl, have you started using it?
I've had a couple of patients who have used the platform, but this particular iteration, I think, is just that is dovetailing with the AMDA advanced care planning template. I think that's still, the kinks are still being worked out, if I'm not mistaken. Okay. But Brian, correct me if I'm wrong, but it is already available. It's available online, and it's really good for anybody. I mean, it's good for young, healthy people who just want to make sure that they've got their, the person that is going to make decisions for them, that's available, and it's cloud-based, so it could be accessed anywhere.
So I see it's been launched.
Yeah, so the platform's been for 10 years and is available to click. So people can go to mydirectives.com and do an advanced care plan. The facilitated version of that, where a provider can generate that document on the patient, that platform is live, but in our work with AMDA specifically, as that comes out into full release, there's training guides and access modules access instructions, obviously, in terms of how that'll come about. But like anything, and I think we, touched on this, it's, you want to keep the workflows simple for providers, simple for patients. And that, to me, in my role where I got into technology around healthcare, I like technology, but really I'm an efficiency junkie. I hate doing something twice if I can avoid it. And so to me, technology is really a tool and a vehicle to make sure that we complete these documents, that they're done, they're portable, and we're not repeating that process again and again, opening that document when it matters.
Well, thank you very much.
So Aaron from AMDA, Aaron says that it is actually already available, and it's on the AMDA website. So I'm maybe a few days behind the times or something like that, but please do check it out.
Okay, yeah, I will check that out and see what the acceptance of my patients may be. And this may be a good time actually for Tutus to launch something like that. So we haven't gotten too many questions. We do have a reference here for the JAMDA article that was published. Thank you, Kevin. I would actually like to circle back to you a little bit, because I think our listeners could benefit from a little bit more explanation about how VitalTalk works. It's not, I understand, you don't just ask, would you like to be resuscitated? But it's a different way. And it is not entirely patient-centered. Well, I wouldn't say that. Tell me, it's not entirely, it translates something that the patient wants into a advanced directive. Is that correct?
Yeah, exactly. I mean, the Post is of course a wonderful tool as a portable medical order, and all states have a version of Post. Essentially, all residents of nursing homes or post-acute patients in nursing homes would typically be appropriate to at least have a Post considered. But what we find is that in many facilities, perfectly well-intended clinicians and social workers and other staff members, present the Post to the family or the patient and say, and they kind of treat it as, they use that checklist and say, do you want to go to the hospital? Do you want dialysis? Would you want a feeding tube? And while all those questions are well intended, they're generally not fair. How would the patient or the family member know how to answer those questions, right? How would they know if those treatments match up with their values in the context of their prognosis? And that's the advantage of the Ariadne Guide and others, that you don't focus on what treatments do you want, but the questions are about, what are your goals? What do you fear? What do you worry about? What are your strengths? There is a question about trade-offs. What would you be willing to go through for the possibility of gaining more time? So the questions are about values. And they're also in the context of prognosis. I do want to make that clear. I think one of the, again, like the silver lining of the COVID pandemic is that it's so clear to even most lay people that if you're an elderly nursing home resident with comorbid conditions, if you get COVID, you're likely to die, or it's horrible rates of mortality. And so that's one reason it gets people's attention. We need to talk about this, and so that when you're able to relate prognosis to patients and families at the beginning of the discussion, share about prognosis, and then shift to what are your goals? What do you fear? What do you value? Then once you learn that, then that's the time to then make a recommendation that would include perhaps a post. It would include items that would go in, the AD vault. Once you've learned values, then you make recommendations. And that's what those structured approaches have in common. They shift the clinician from asking about treatments to asking and listening about goals, and then from that making a recommendation.
And how do you get to the recommendation? I'm sorry, let's follow up, and then you. How do you get to the recommendation? Are they algorithms or pathways, or is there special training that you can undergo?
Well, good point. That sometimes is one of the hardest things, especially for inexperienced clinicians, right? The idea of making a recommendation that, based on your prognosis and your values, being intubated in the setting of COVID won't help you. That's a hard thing for a lot of clinicians to do. And it takes practice, training, support. It's tough. But at least if you use the structured approach and use some of the sample language and practice, it gets easier. Yeah.
Okay, and there's training sessions out there that. Oh
yeah, right. Through lots of different organizations. Mm-hmm.
Okay, all right. And I think we have some of those on our Washington AMDA chapter memorialized. So if you're interested, otherwise you just do Vital. You just can Google Vital Talk. Carl, did you want to?
I was just going to say. Yeah. Can you hear me? Okay.
Yeah.
Okay. I took the Vital Talk training at one of the AAHPM meetings. It was a day-long training, and I felt like I was already pretty good at having these conversations with people, having done it for 20+ years, and I picked up some tips. And some people say, well, I don't really want to learn an algorithm, or I don't want to go use a script because it's not spontaneous, it's not authentic, and I think, especially for people who are not kind of naturally inclined to have these types of conversations with people, it is super helpful. Probably most people who are on the webinar now, and most of us in this arena are pretty decent at it anyway, but you can always get better. And so I do recommend that. And the little app that you get on your phone, it gives you reminders, and there's little mnemonics and things like that. And you don't have to use every little bit of it, but I do find that it's very helpful. And it's really important to listen. As Kevin said, sometimes we're just so busy chit-chatting and telling people what we know, not making sure that they're hearing what we're saying, and we're not really contextualizing it to that individual person. Is there a graduation they want to be around for, or whatever it is? Are they particularly private people, and incontinence is going to be a big issue for them? All those types of things.
Mm-hmm. Well, thank you.
I just wanted to chime in. I think something that really ties this all together, and we say it all the time, is the goal drives the plan. Right, so that's really what was being described by all of us. Is this goal has to be known and understood in order to drive any of the plan. And once we have that information, I'll say that one tool that we sometimes use to translate into what that plan is kind of a talkback tool, right? So in my head, I might figure out what I think they mean by that. Right? And then when I reflect it back to the patient or their family, I'm using the person's words, but applying them to the medical interventions that they may or may not want. And in doing so, it allows them to dissent or agree, with my interpretation, but then it also allows me to sort of document things in a way that, looking back later, frankly, I'm going to remember that conversation because I've included their words along with their goals.
That's a beautiful
and
way.
I would just say when we're doing these conversations, it's really nice to have that actually documented. Just like Jessica said, it's sometimes you see a post form, and in San Diego here, sometimes the emergency room docs, they're like, I'm just not going to follow this form. I mean, it doesn't say anything about the conversation that preceded it, and I'm reluctant to follow it. It's much more compelling when you have some documentation of what was actually said. So the other thing that I picked up, as far as using that sort of teach back method, and I used to find it, people, if I used to say, tell me what I just said, they feel like you're being challenged, or you're giving them a test and that. And so I learned this at Vital Talk, is to say, sometimes I don't communicate that well, and I just want to make sure, if you don't mind, can you tell me what I just said, because it'll help me, right? And that makes it much less threatening to them, and so I use that a lot now.
Okay, well, thank you for those comments. Would anybody like to make or contribute to this discussion for the specific situation of COVID? So we talked about patients being actually more engaged right now, having specific requests around COVID. Are there some patients who also so that seems like more wanting to have these conversations. Are there also some patients who now say, I don't want to have that conversation, or I can't make that decision without my loved ones at the bedside? Is there some vulnerability that patients express now that you have observed, saying, you know what, I'm here by myself, nobody's with me, I can't really do this, and I'm really scared and depressed, and leave me alone? Or what, have you observed that, and how have you dealt with that?
I'm sure it definitely happens, Sabina. I mean, some patients and families are afraid to talk about this. And one of the good things about these structured guides is the first question in the guide is a permission question.
Yeah.
Can we talk now? I want to talk about your illness. Is now a good time? And so they can say no, and sometimes do. And you follow up, you try again in a few days. You see if things are a little bit different, and maybe they might be interested, but you have to ask permission. Absolutely. They need to be ready to have the conversation.
And I really do like that about Vital Talk. I think that's quite beautiful, really.
The other thing, and we talked about this a little earlier, is although their family may not be next to them, we really can engage them. It feels different. And frankly, some of what this isolation has potential to do is having residents or patients make decisions that we've talked to them about, and perhaps us not making or finding the time to make sure their families know what these new decisions might be. And so there's actually great risk of a disconnect and potential, down the road, really frustration by family members or or patients about these conversations. And so I think it's, particularly more important to help those that make decisions on their own understand that we're going to communicate with their family, or even more so to bring them into the conversation.
Mm-hmm.
Because there's a vulnerability there that always exists, but it feels really different right now.
Mm-hmm. Mm-hmm. I think that's very well said. Are there any other comments you would like to make? Because I have one more question for Jessica in particular. I don't think I see anything on the chat right now.
Sabina, I have a cool anecdote, if you don't mind. If you could hear
love it. Go for it.
That gets at the reluctance that a lot of clinicians have about using a checklist or a structured approach to these conversations. That's totally natural. A lot of us, especially with experience, I don't need that. I don't need a checklist. It would be awkward. Well, it turns out the founder of Ariadne Labs is Dr. Atul Gawande. I assume we're all familiar with him, the noted surgeon and author at Harvard. One of his first books was the Checklist Manifesto that changed the way operating rooms work and many parts of medicine for the better. And apparently several years ago, he was struggling with these conversations with his patients. And he went to his colleague, Dr. Susan Block, an internationally known palliative care doctor, and said, "Susan, how do you have these conversations?" And she said, "Well, we ask about goals and fears and, what are your strengths? And, there's some things we talk about, and this is kind of how we do it." And he said, "But Susan, don't you have like a checklist or a form?" And she's like, no, that wouldn't work. We don't do it that way. And he said, no, you need a checklist. We need to do this. And I don't think the story's apocryphal. It's pretty cool. I heard it once. And, so he inspired her to develop the Serious Illness Conversation Guide, kind of in the context of his obsession with process improvement and checklists and things of that nature. So apparently that's kind of how at least that particular guide came into being, from someone who recognized the value of a checklist. And I think that's
checklist fan.
Yeah.
I would just add into that. I think checklists are important. When I freestyle an approach, it's not unusual that I've forgotten to ask a question because we go down a tangent. And intention, it's just I got sidetracked. But the other thing, and so a lot of times just the simple checklist can save me going back or reopening a long conversation potentially. I think the other thing, a systems-based approach in terms of having that pliability, so you checklist, but your checklist has to be flexible in terms of how you use it and you advance through it. And then ultimately and so this is one thing that we're doing, this limitation families coming in to the facility. That restriction right now, we're using telephone or FaceTime to help bridge those gaps with families and residents. But with advanced care planning, that I think something that's probably here to in terms of creating in a digital fashion, but also using technology to bridge those communication gaps so that we're not having that conversation in a vacuum.
Thank you. I have a question for Jessica, and it is not really about advanced care planning, but it is about the care, the end-of-life care of patients with COVID. What have you learned? And I know we only have a few minutes left, but I think it would be a good time to discuss what you have learned, what the special needs of COVID patients are at the end of their lives due to COVID. And you talked about the compassionate visits. Anything else that we should all know moving forward as we will see more end of life due to COVID in our space?
It's interesting. I think when we were all gearing up for this, at least in the recent months, we reached out to facilities to make sure they could get some extra medications on hand, extra morphine or Ativan or whatever was the flavor of the day in case there were shortages everywhere to make sure that, you know, our patients at end of life really had that availability. What we found, though, and I'm curious to hear if others have had the same experience, was that the things that people needed were, from a medication standpoint, were pretty limited. It seemed like as people got worse, they really passed away relatively quickly compared to many other things that we're used to seeing at end of life. And so the shortages, while they exist, I'm sure, in some areas of the country, were not nearly as big of a deal in a lot of cases for our patients that didn't require IV medications. We also found that we used some more clysis, you know, subcutaneous infusions if needed, when we were in this kind of gray zone of what, you know, pathway we were taking. But for people that we thought were going to head towards a comfort care pathway, we definitely used more clysis than we normally do. You know, the other piece, I think it all comes down to that, like, touchy-feely piece, you know, time, setting aside time to sit with people, because even if their families came in, they didn't come in and sit there for hours like they normally do, right? They came in and sat for 10 minutes in full garb, you know, where they couldn't even really see what their loved one looked, you know, the patient couldn't see what they looked like. And it isn't the same. And we relied so much on the long-term care facility staff. Those people are truly elevated in my mind, really beyond any. I already had a lot of respect, but it is just skyrocketed.
Yeah, I have seen a lot of beautiful out of the box thinking, going out of their way, staying late so that this compassionate care visit could happen, or that the priest could come, or the Korean woman who was laid out in garb, or, you know, there, a lot of beautiful moments have really happened. Moments of true humanism and love that was shared by staff. And maybe we'll stop at this proclamation, because it is really another, it's not even a silver lining, it's something else we have learned, how much compassion and love all of our staff is capable of when asked and taken to the task. And that has been a beautiful thing to see. So thank you, everyone, for taking time out of your busy schedule to join us today. I think I have greatly enjoyed talking to you all, and I've learned a lot. We talked about a Vital Talk, a structured but not rigid approach, goal-driven, not so much procedure, decision driven. We talked about the ACP module that AMDA has, and a way to document that so it is truly portable. We talked about TPOP, which is like, that was like the highlight, TPOP, and the opportunities that we have seen, the engagement of family, the special vulnerability that we need to be aware of. And once again, telemedicine can be a really good tool here in this area to engage the loved ones in the process. And with that, I want to thank you, and I want to make you all aware that we'll continue with pearls from your colleague. Let us know of what questions you have that you want to have addressed by your peers. And thank you for all you do, and please stay safe and well. Thank you very much. Bye-bye.